Dear colleagues, we are new in Harmony. We means the CML community, but we are not new in clinical research. Of course, we have done a lot of collaborative research in the past, and therefore I'm very happy that we can contribute to Harmony now as well and can benefit from Harmony. It's good that I talk after Jan, because Jan knows very well that we did a lot of projects, common projects together, and I'm sure that we will continue here within Harmony in the same way. I speak on behalf of Sue Brantford and Thomas Ernst, who are really responsible for the work on clonal hierarchy in CML. We know and we have learned in the last 30 years that BCR-ABL is a driving force in CML in most patients, a genetic hallmark. We have focused on BCR-ABL in resistant patients. We have looked at specific point mutations in BCR-ABL, but now we know with the development of next generation sequencing, we know that we see clonal evolution and BCR-ABL independent clones with epigenetic mutations in about a third or a quarter of CML patients, and we want to elucidate whether these clones are important for the clinical outcome. We know that they may herald blast crisis, but we don't know about treatment-free remission, if they influence treatment-free remission in these patients, if they influence the activity of a BCR-ABL specific inhibitor, which is asciminib now as a inhibitor which has no off-target activity, may be a big advantage for the tolerability of the drugs, but may be a disadvantage for the broad spectrum of clonal evolution. This needs to be developed, all this knowledge, and therefore NGS strategies are very important now for the routine use in clinical trials in CML patients, and therefore it's advantageous to collect this data in a single platform, in an individual platform, which is Harmony. Next, please. We have these scientific questions. I already mentioned some of them. We know that additional cytogenetic aberrations at diagnosis have a prognostic impact, and we differentiate high risk and low risk additional cytogenetic aberration. This has been established. We see Philadelphia negative clones, that means clones in the normal hematopoiesis, which may be age-related, which may be just normal chips, but they may have a clinical meaning because they come from an individual stem cell which develops into a BCR-ABL positive cell, and on the other hand, in other clones. Therefore, it's very important to check the molecular aberrations in Philadelphia negative clones as well. And most important is, of course, the clonal evolution in the Philadelphia positive cells itself. We see them at diagnosis, but also later in the evolution of the disease. We see BCR-ABL on chip, and we see clonal selection of BCR-ABL specific mutations. And I think the most interesting part here is the persistence of BCR-ABL positive cells in deep and complete molecular remission. And we need to reveal why these BCR-ABL positive cells persist despite the activity of tyrosine kinase inhibitors. Next, please. So this is the example of the high-risk additional chromosomal aberrations. This is a background for our research. This has been published by Rüdiger Hehlmann based on CML4 data recently. You see that trisomy 8, second Philadelphia chromosome, derivative 3, 7, 17, 19, and 21 are considered high-risk cytogenetic aberrations, and they herald blast crisis, and therefore it's important when they appear at diagnosis to consider transplant in these patients very early. Very rare, but important for the individual patient. Next, please. And we know this is data from several labs worldwide collected by Sue Brentford that several molecular aberrations detected by next generation sequencing may have an impact on outcome of these CML patients as well. But there is no collection, there is no large collection of such patients. Therefore, it's important to put all the knowledge together and to put all the efforts together which are currently ongoing to reveal the importance of these genetic aberrations. Next, please. This is the group which has been established by the International CML Foundation, coordinated in Adelaide in Australia. And you see that a number of labs have focused on this next generation sequencing data so far, and we published a paper which may be the background for our future work, which collected the research questions. And we have done this in close contact with Jan and the CML Advocates Network, and therefore this needs to be continued. But so far, we didn't find a platform to collect this data, and Harmony is of course a good chance. And since labs outside of Europe have now the chance to contribute to Harmony as well, it's of course obvious that we come together and do it together. Next, please. So we need the larger cohorts, and I already summarized this to find the answer to the specific mutations, which may be rare, but we need to find the evidence for each individual mutation for the importance in the CML biology. Next, please. So this is the paper which I mentioned on behalf of the International CML Foundation. This has been published based on the interim data from the various labs which I demonstrated, and we have collected here now, and this is the background for our project here, the European Leukemia Network Package 4, which is CML labs, the Utah sequencing labs, and the International CML Foundation Genomic Alliance. There is some overlap between these 3 points, but all in all, this collects global knowledge on mutations in CML patients. Next, please. So, and we have 4 sub-projects, which I want to briefly highlight: the BCR-ABL independent mutations at diagnosis, the evolution during TKI therapy, molecular aberrations during and in front of advanced disease, and mutations detected in single cells and specific cell populations, that means in treatment-free remission. Next, please. These are the independent mutations. This is the current knowledge. You see that most important are the BCR-ABL kinase domain mutations. But in addition to that, we have RUNX mutations, we have A6L1 mutations and others. There's a wide range of different clones in CML, and the individual importance for the outcome of these patients is still pending. Therefore, need to collect this data. Next. Number B is the evolution of BCR-ABL independent clones. We have 3 patterns. One is persistence of the clone despite tyrosine kinase inhibitor treatment. One is emergence of a clone on treatment, and one is complete clearance of the clone with the BCR-ABL inhibition. That means the mutation was closely linked to BCR-ABL and was eliminated by the elimination of the BCR-ABL positive clone. Number C, please. Next. The molecular aberrations during advanced disease have been collected in a number of patients and published by Sue in Blood in 2018. In the last 2.5 years, of course, many more data have been collected here and needs to be put together in a platform. And last one, D, is treatment-free remission. And in treatment-free remission, it's important to check why BCR-ABL positive cells on the genomic level persist in the bone marrow. Therefore, for this project here, we need bone marrow in addition to peripheral blood, and we need to check the different cell types. That means lymphocytes, B lymphocytes, T lymphocytes, myeloid cells, in parallel on a single individual cell level and check the sequencing data on this level to find a predictor for the duration and stability of treatment-free remission. Next. So this is, I don't want to go into details from the statistical analysis plan, but this has been established already. Next. And in addition to this project, I want to mention that we still have the UTOS registry based in Munich, which is a collection of 6,602 patients with follow-up, which may serve as a comparator for all what we do. That means that's a huge database which is available for Harmony as well as a comparator database for the newer the latest treatment options. Most of these patients here have been treated with imatinib, but now, of course, we have 5 inhibitors in clinical practice and 1 in research. And this may be important to have this database in the background. And next, now the progress since the last meeting. Of course, in the last meeting, we were introduced into Harmony. Now we have invited all the International CML Foundation and UTOS partner labs. We started the definition of a CML-specific dictionary for the database. That means the molecular data and, most importantly, the clinical annotation to this data. And we need to do, and that's of course a little cumbersome, but we need to do the paperwork for each individual lab to partner with Harmony Plus. Otherwise, the individual lab may have internally a problem to participate. Therefore, I think this should be finalized parallel to the definition of a CML-specific dictionary, which is in good progress. And final, our roadmap is to invite everybody who's interested. That means it's an ongoing process of making Harmony available for all CML labs. We will do this on our next Work Package 4 meeting in March in the ELN context. We have to agree between these labs on this dictionary, which I already mentioned, and we start the collection of annotated sequencing data, and we'll have several meetings where we report on the progress of our Harmony project. And we are very grateful that we did it now. We made it, and you invited us, and therefore I think hematology is now almost complete. CML was missing in this context, and we are here. Thank you very much.
Thank you, Andreas. And this is really important to see the progress in the last 4 months for this CML project. That is really extremely important for all of us. And I know that the paperwork that we have to do is a little bit, it's not irrelevant, yeah. But in any case, it was also performed by the other teams, and I'm quite sure that CML will be also there. So, and also I'm really impressed about the extension of this working group in CML covering all the continents and the most active teams on the field. So congratulations for this. And hopefully we will continue to grow. And this meeting on March seems to me that it will be really very important.
Yeah, we are in good contact with Lars Bullinger, who will help us on the dictionary. I think that's a good basis to have the advantage of having the AML dictionary available. And I think this is the first step. This will be done in a few weeks, and then we need the agreements with the different labs.
Dictionary is key, of course. Okay, let's move to the next presentation. This is the update about in ALL. ALL is also growing, and now we have over 10,000 cases. Some of these cases start to be analyzed by the team working in Newcastle University, and Anthony Moorman will provide the update. Anthony?
Thank you, Jesus.
I don't see you in the room, but I see you on the screen. You know, it's quite difficult here. Okay, thank you for coming, Anthony.
Thank you, Jesus, and thank you to all the organizers for inviting me to give you an update on the ALL project. I'd like to point out in advance that this is a joint presentation between myself and Jordi, and also Hannah, who's my project manager, and Javier, who's been helping me with some of the analysis. So essentially, there are two types of projects that have been submitted and approved by the Harmony Alliance to do with acute lymphoblastic leukemia. I'm going to talk about the two ones at the top here, which are the academic projects that are based around data collection and analysis. And then Alexander from Pfizer is going to talk about the two projects that they have submitted from the pharma side. So essentially, the data collection and analysis projects, can you advance the slides, please, can be summarized by this graphic here. So what we really wanted to do is create a European knowledge bank for evaluating a number of risk factors in acute lymphoblastic leukemia. As I'm sure you're all aware, this is one of the rarer forms of hematological malignancy, and therefore establishing robust risk factors that you can use in the clinic really does require people to collaborate across countries in order to pool data sets that are large enough to provide robust estimates. So what we wanted to do is start to pool existing published data sets for secondary analysis. We wanted to do this for patients of all ages, and also we wanted to incorporate as much existing genetic annotation as we could. The idea we would then pool all these clinical trial data sets onto a single platform, i.e. the Harmony platform, and they would then become available for more robust analyses. We would then be able to add new data sets as and when they are published and come online, and we would then be able to also upgrade some of these data sets to incorporate additional data. This not only would allow us to generate high quality and in-depth analysis of risk factors in ALL, but it would also be able to allow us to contribute to pan-hematological studies, which we believe would be very useful going forward. And the overall aim here was to collect between 15,000 and 20,000 data sets. Next slide, please. So the main objectives of the two academic ALL proposals are summarized in this slide. The project that I proposed was really, what I really wanted to do was to start to validate existing prognostic factors, particularly the rare genetic subgroups, and also profiles and risk scores that we've been developing in the UK on much larger cohorts of patients from across Europe. We also wanted to start developing new models for predicting outcome, especially in those key areas of unmet need, which are the subtypes such as T-cell acute lymphoblastic leukemia and also some of the rarer subgroups, and also to avail ourselves of some of the novel methods that will become available from having this kind of big data. Jordi's project is focused very much on Icarus deletions, which, as I'm sure you'll be aware, are one of the most prevalent microdeletions that occur in acute lymphoblastic leukemia. Their prognostic impact is reasonably well established in pediatric ALL, but their prognostic impact in adults with acute lymphoblastic leukemia, and especially what clinical intervention should be made on the basis of those deletions, is not clear at all. And what Jordi and his team are planning to do is collect a large amount of very detailed data on these type of deletions in order to establish a clear prognostic relevance of Icarus deletions within adult ALL, and also plot out exactly how that can be used in the clinic. Next slide, please. So both Jordi and I approached these projects in a very similar way in terms of recruiting data providers. We contacted the IBFM and also EWAL, that are the clinical study groups that operate in Europe for pediatric and adult ALL respectively. And we used our membership of these two groups to instigate discussions with the clinical trial coordinators of all the study groups that you see listed on this slide, and request that they start submitting data to the Harmony project. So as you can imagine, this took quite a long time to convince everyone. Setting up data sharing agreements is not a trivial process, However, we have made significant advances over the last couple of years. If we move on to the next slide, this table here shows all the data that is committed by 8 of the study groups. The name of the group is shown down on the left, and the number of cases is in the middle. And if you add all those up, they come to just shy of 11,000 patient data sets. So the crucial thing here is that they're coming from all parts of Europe. There are some very large data sets coming from the UK and also the BFM NAOP, which is the German and Italian cooperative group, as well as smaller data sets from other countries. But all these data sets will be useful. It will be important to evaluate risk factors both in the very large, well-established clinical trial structures, but also in more population-based cohorts of patients. So it's very encouraging. So all this data has been submitted now, and we now are on course to hopefully attract an additional 5,000 cases from the study group shown here. The 2 listed in green have shown very keen interest in the last week or so, so I do believe that they will come on board very soon, and we'll be trying to attract the other 2 in the coming weeks. So if there is anyone else out there on the call who is a representative of any other study group that has acute lymphoblastic leukemia data, then please do let me know, and we can set up a communication with the clinical study group to look at them joining the project. So as I mentioned, we already have some data on the Harmony platform, and what we've been doing so far is starting to explore these data and also to start the process of validating to ensure that the data that we have provided to the Harmony platform after it has been mapped onto the common model still produces the same results. So reassuringly, the age profile of the 3 data providers shown on the left is as it was expected. The one in blue is a pediatric cohort, the one in green is a young adult cohort, and the one in red is a more traditional adult ALL cohort. And so when we look at the age patient, that maps on very well. We've also started to look at a number of risk factors, which are shown on the right-hand panel. And here what you're looking at is the odds ratio of a number of risk factors, where the yellow dot is the risk estimate and the line is the 95% confidence interval. And I'm sure you might have some struggle reading some of the risk factors, but essentially the key thing is that all the risk factors are to the left of the line, i.e. associated with a good outcome, are the ones that you would expect in acute lymphoblastic leukemia, whereas the ones to the right of the dotted line, i.e. indicating a higher risk of relapse, are again the ones that are showing the high risk genetics, a high white cell count, etc. So if you move on to the next slide, what Javier has been very helpful doing for us is to do a formal validation of the data and comparing it to previously published data. So this was data provided by the UK. The 2 graphs shown on the top here are from 2 separate papers that we published a number of years ago, and that the 2 graphs on the bottom is Javier's replication of that analysis using the data on the Harmony platform. And essentially the results are exactly the same, which is very encouraging. And if you move on to the next one, what we've also been able to do is start thinking about some more novel analytical ideas. And Javier was looking at some classification trees, which is not something that we had looked at previously. We looked at linear models and multivariate Cox regression. And what he found, as shown by this kind of insert here in node 19, that if you combine our prognostic index that we published a year ago with white cell count, you can identify a small but very important cluster of patients that have a very poor outcome, with a survival at 5 years of just 40%, which for pediatric acute lymphoblastic leukemia puts it into an ultra high risk group. So that's just an example of how once you get this data on the platform and you have analysts looking at this data, they instantly provide new ideas to you and start looking at your data in a more novel way. And the little panels on the right, again, courtesy of Javier, is work that he's actually done on AML that I'm sure Lars will be discussing later. But he highlighted this to us because his use of non-linear models has been very useful at establishing the risk associated with ultra-rare subgroups, which in ALL is something that we really struggle with. So we're going to be applying these methods to our data set in the not so distant future. So if we move on to my summary slide. So the project had a slow beginning, I'll admit that. Convincing people to submit data and getting that data sharing agreement signed has been challenging. But by June this year, we will have cleaned and validated well over 11,000 cases, and they will be ready for analysis. We are still trying to collect additional data if possible, but as GMV showed earlier, or as Jesus showed earlier, GMV have now provided some really useful tools on the platform to explore these data. We are getting people involved from Newcastle University to develop analytical pipelines that will be able to look at this data in more depth and at a very good speed. So the initial data analysis has been fruitful, as have the interaction with the Harmony analysts. So overall, the project is going very well, and I'd like to thank everyone who's been involved, in particular Anita Keinsberger, who has been very useful in the pediatric ALL community about convincing people to contribute data and oiling the wheels to make sure that those data sharing agreements get signed. So I'll end there and pass over to Alexander from Pfizer, who will give a short update on his two projects. Thank you very much.
Thank you, Anthony. So my name is Alexander Russell-Smith. I'm an outcomes researcher at Pfizer, and I'm just going to briefly overview the two new research ideas that myself, my colleague, Dr. Alexander Neuhoff, have proposed in ALL. So these are two of the projects from the dashboard that Jesus showed at the start of the call. So the first of the two proposals looks at outcomes of older B precursor ALL patients. So whilst the disease is most frequent it is the most frequent malignancy in children, it tends to have a second incidence peak later on, so in patients diagnosed above 55 years old. However, we find that there's only really limited data available for this older subgroup of patients, and we see in both retrospective and clinical trials that the proportion of patients included who are older than 60 is often considerably lower than younger patients. So we wanted to use Harmony to combine data from multiple sources to provide a decent enough sample size so that we can generate more robust results on prognosis and on current therapy outcomes. So we're going to be looking to include all patients in the Harmony database above 55 years old and who have a thorough enough data set on file as well. I'm going to be looking at this population as a single group. So rather than comparing to other age groups at this stage, just looking at it as a sort of single arm study. We do want to look within subgroups, however, look inferentially if possible, if the numbers allow as well. And really, we're going to be looking at median overall survival as a primary endpoint, but also want to have a look at earlier endpoints such as response rate, proportion of patients with minimal residual disease, the rate of subsequent stem cell transplantation as well. And I think that when we get to the end of this project, in terms of the impact, we hope we're, of course, able to bridge a gap in the current literature and knowledge base, but also allow physicians making treatment decisions for patients, better predictability in outcomes for this group, perhaps, as well as being able to benchmark for future research in this population and aid the design of any future prospective clinical trials. Thank you. So on to the second slide. So the second project, we wanted to look at outcomes post-stem cell transplantation. So transplantation is, of course, a common treatment goal for patients with relapsed refractory ALL, if possible. And whilst we see both registry data and reviews of the literature that have been conducted to synthesize the existing evidence on ALL patients' outcomes post-stem cell transplant, I've often found that these reviews focus on patients treated in the frontline setting for de novo ALL, And whilst the data tends to be more sparse the further down the lines you get and in the relapsed refractory setting. Further, because of the small patient numbers, the time taken to collect longitudinally registry data can be a while due to small sample sizes. So often you see published registries and studies spanning a decent enough sample size going across a decade or two and dating back maybe 20, 30 years in some cases. And it's important to know how transplant practices have improved over time, and so have patient outcomes in that time. So we wanted to collect something modern as well. So as well as bridging that gap of data sparsity, and particularly long-term outcomes, we wanted to look at it just as a single group, like the first project I was talking about. So not really comparative at this stage to patients that haven't had transplant, but just have a look at those who have, and focus in on the relapsed refractory setting where we think the data is more sparse. Again, looking at subgroups within the whole data set, if the sample size allows, things like age, number of salvage regimens prior to transplant, how outcomes post-transplant may differ depending on MRD status going into transplant as well. And when we get to outcomes, I think due to the anticipated shape of the survival curve post-transplant, in that we would expect it to drop in the initial year or two after transplant, but then maybe become less steep and likely reach a point of a degree of plateau after 3, 4, 5 years if patients are still alive post-transplant. We didn't want to just focus on the median, perhaps, because that might not tell the full story of a survival curve whose gradient changes over time. But rather look at survival rates at 1 year, 2 year, ideally 5 year, even longer if that data allows us. Relapse also an important outcome, I think, as well as safety outcomes such as VOD post-transplant, GVHD as well. And the impact of this project is obviously adding to the literature is important, but we want to be able to have these data available to enhance treatment-making decisions by identifying prognostic factors in our data set, as well as being able to be poised to join with other potential studies from neighboring data sets too. And if we can answer longer term outcomes, particularly with respect to survival probabilities with modern day transplantation in this relapse setting, I hope this should also benefit and better inform patients of their prospects post stem cell transplant. So yeah, that's the 2 new research proposals, and I will hand back to Jesus.
Thank you, Alex. Thank you, Anthony. I think it is clear that ALL is really progressing, a lot of data coming. And I think it's, we have to be optimistic, and we have to be that maybe we will have even more than 1,100 cases on June. I hope this figure we will reach maybe on April or even before. So I'm quite optimistic about it. Okay, let's move to the next presentation. Is regarding myeloma. And in myeloma, there is a real effort coming from the European Myeloma Network, who is really helping Harmony a lot, identifying the data sets and identify the potential providers. And I think European Myeloma Network is very well organized, and it is the main reason why we reach really these 7,000 cases in a very short period of time. And now we have to keep in mind that we have to take some progress also on this. Mattia D'Agostino from University of Torino, from the group of Mario Boccadoro, will do the presentation. Mattia, thank you very much for accepting to do the presentation, and go on.
Okay, good afternoon, Jesus. Thank you for inviting me. Good afternoon to everyone. I'm Mattia D'Agostino, and on behalf of the key opinion leaders in multiple myeloma, I will explain you what we are doing in myeloma and the progress that we made in the last months. Next slide, please. So as a pilot project, we started a few years ago to think of ways to improve prognostication in newly diagnosed multiple myeloma. So in newly diagnosed multiple myeloma, the main prognostic score that has been used in the last years is revised ISS, that has been published in 2015. but we think that we can improve it. So we started this project starting from the revised ISS in order to improve prognostication in newly diagnosed patients. As Jesus mentioned, we through European Myeloma Network, we convinced the groups that did the trials in Europe to provide data into Harmony platform. And now we have more than 7,000 cases of newly diagnosed patients enrolled in a clinical trial. We are expecting to receive very soon a large data set from UK, 4,000 patients. And the contract between EMN and the UK Myeloma Research Alliance is being signed in these days. So I'm very happy that they agreed to provide data and to possibly validate our findings. On the right, you can see the main variables that we collected are mainly prognostic variables and, of course, the treatment that each patient received. Next slide, please. So, exploiting the large number of patients that we can analyze into this platform, we analyze the impact on overall survival and progression-free survival of each risk features. And as you can see on the left and the right, ISS and cytogenetic abnormalities and LDH are the most prominent one. Next slide, please. So as you can see, the first five, the top 5 risk factors as an international staging system, and that is based on the beta-2 microglobulin and albumin, deletion 17p, LDH, translocation 414, and 1q copy number abnormalities. I want to stress that 1q copy number abnormalities are not included in the current revised ISS. And what is included is translocation 1416 that here have only a minimal role on overall survival and does not have a significant role on progression-free survival. This is very important. Moreover, the large number of patients allowed us to have very, very short confidence intervals, so to have an estimation of the role of each risk features in a very precise way. Next slide, please. So we selected the patients that have complete data on all the risk features. As you can see, here are more than 2,000, and the most the problem is that 1q copy number abnormalities have not been analyzed in the first trials, but we have it for more than 2,000 cases. So exploiting the complete the cases with complete data, we analyzed again the top 5 risk factors, and you can see in the left, and we gave them a score value, and based on that score value, we did another prognostic risk methods that we called revision 2 of the ISS. As you can see on the right, each half point of this score predicts a lower overall survival. And I think that this is the first time that we see a very nice separation on overall survival in multiple myeloma, especially in the intermediate risk group. Because in the previous revised ISS, the 60% of the patients are intermediate risk. And if you see on the right, the intermediate risk patients are very well divided by this R2 ISS. And in order to be more, in order to give a risk score that can be used in the clinic, we grouped the patients. Please, next slide. And we identified the 4 groups that we called low risk, intermediate low risk, intermediate high risk, and high risk. And as you can see, there are patients that have basically 4 different diseases. In low risk patients have not reached a median overall survival even after a median follow-up of 8 years, while the 37% of the high-risk patients are alive at 5 years. Next slide. So we presented this revision 2 of the ISS at ASH. I want to stress that we included 1 Q-copy number abnormalities in the calculation of the risk scores, and we divided very well the intermediate risk patients into low intermediate and high intermediate. This is important because one of the possible treatments that are emerging in multiple myeloma are risk-adapted treatment, and if you have 60% of the patients that are intermediate risk, you cannot do meaningful risk-adapted therapy on a meaningful number of patients. Moreover, this additive scoring system is very flexible. So if you have new variables in the future, this can be easily added because you just recalculate the score. And of course, we are planning to validate these on the UK data in order to publish. So the last slide. So we are waiting for UK MRA data to be included in the platform. I think that they will be ready by April, and then we can do very fast. We can be very fast in the analysis and try to publish these data on a cohort of more than 10,000 patients. There are some other collaboration about multiple myeloma in the Harmony project. So as Jesus mentioned earlier, we are starting a collaboration with ASH Data Hub. They are collecting real-world data using electronic health records, and so we are planning to compare our clinical trial data with the real-world cohort in the United States. I think that many questions can be made and many interesting answers. And now I leave the presentation to Dr. Bell that explain you a new proposal that has been received by Pfizer just a few days ago. So please, team, I leave the presentation to you.
Great, thank you very much. So you see here in the title, the proposal is developing historical control arms in patients with triple-class multiple myeloma. So if we go to the next slide, we'll see some of the specifics. And this is a bit of a high-level concept here, just to pique your interest in it. If we look at the situation and objective, we see that many clinical trials evaluating new therapies, particularly in the later lines, such as triple-class refractory, are using single-arm trial designs. And we know that if coming to market with a single trial or coming to the academic community with a single-arm trial design is going to make comparisons between existing treatments more difficult. So one solution to this is to develop historical control arms to help contextualize the results from these single-arm studies. So not only do we think this will aid in decision-making by contextualizing the results, but it could potentially accelerate regulatory and HTA reviews, which effectively means that these needed medicines, again, especially in later lines, come quicker to the patients. So the patient population that we're going to focus on at first, and this is obviously naturally scalable to others, but again, it's going to be the triple-class refractory patient. And you can see the definition there. And the key component here that has been discussed is around data sources. And I think the ask and the opportunity here, especially with this type of group of experts, is really, can we rapidly identify and get within the Harmony neighborhood any types of data from phase 2, phase 3, phase 4 trials or real-world data registries, but effectively to start developing a set of data with these refractory or relapse multiple myeloma patients, and then we could start defining the triple class cohort. So there's a real urgency and need to get these data sources, and we look forward to collecting that. The endpoints of interest, not surprisingly, are your common clinical outcomes. So overall survival, tumor response, progression-free survival, and even better, if we have patient-reported outcomes. As we know, this is a patient-relevant endpoint and of increasing need to know both in terms of, the quantity of clinical outcomes as well as the quality of clinical outcomes, if you will. On the next slide, just to aid with the conceptual illustration here, what we have is on the left-hand side under Circle A. So we're going to have single-arm data from multiple sponsors within the triple-class refractory population. What we hope to get on the right-hand side is using Harmony data sources to create these historical control arms via matching the samples using various statistical approaches. And then by having both A and B, what we're able to do is make comparisons with this. And we think that will help better contextualize these results and aid in decision making in the community. So that's it. That's a quick snapshot of our proposal. And again, I think just to reiterate the ask, we're looking for data sources, which I think within this group, we'll achieve that in the short term.
Thank you, Tim. I think it's a very, very interesting approach. So it's a kind of new idea, new concept that we can also develop in Harmony. I really thank Mattia for the presentation, and also you. Mattia, maybe you are thinking to send something to the EHA? Maybe some new results or some new analysis?
Jesus, I have to think about it when I have the timing of the UK data intake. I think that this has to be, I mean, we can write an abstract as a sub-analysis on response, for example, because the R2 ISS is independent of response. It works in PR, VGPR, and CR patients, but still, I think that the true story will be out when the validation cohort is in the platform. So we have to discuss it internally, but I think that it's better to wait for the the validation cohort in order to have a complete story.
Okay. So thank you so much. And then also I like to thank Pfizer for this contribution in this couple of topics in ALL and myeloma. So during many times we were asking also the proposals coming from the industry, because they are also very important for all of us, and also they are really attractive ideas, and in some way new ideas coming from the room, and they are really very, very nice initiatives. And as much as we can help and we can identify these databases, we be sure that we will do in ALL or myeloma. Thank you so much, and we will move to the next topic. It will be CLL, and this is a project, a common project with Eric. Eric, you know that this is the European research in CLL, and in this project has been mainly involved not only Professor Paolo Villa, but also Professor Rosenquist, Leslie Ann Sutton, and Larry Mansouri. I think Paolo will do the presentation if I'm not wrong.
Yes, no, thank you.
Okay, perfect, Paolo.
Yeah,
go ahead, and thank you so much for accepting the invitation, Paolo.
Yes, thank you for inviting, of course. And indeed, we will be presenting two different projects. So this is the one that you mentioned also in your introduction, and that it's completed. And indeed, Richard and Leslie and Larry took the lead of this project, and they are gonna. We already presented the final data in October at the last Harmony meeting, and they are preparing now an abstract for EHA, and together in parallel with the publication. So by June, we hope to have both presentation, poster maybe, and the paper. So I just want to make it a very short story, just to remind you what this is all about, and then Lydia Scarfo will be presenting the second ongoing project on CLL within Harmony, where we will see more than 10,000 patients are going to be collected, even approaching probably 15,000 if we are lucky. So the first project was indeed aimed at designing a prognostic model in CLL, taking into account also the gene mutations that have been identified in the last few years in CLL, none of them being really prominent in terms of percentage of patients involved. So they are all affecting between 1 and 5% of patients. So it becomes very difficult to understand the real prognostic value of all these gene mutation if not assessed in large cohorts as we made it possible within Harmony. So in the next slide, this is a project that involved 26 institutions in 12 different countries, and we collected, as you see, almost 5,000 patients. Already 3,000 and something are in the database within Harmony. The remaining will be transferred in the next few weeks. In the next slide, we do see some of the institutions, but we can move quickly to the next one just to recover some time also. So these are the patients, as I said, almost 5,000 patients where we collected the data about the gene mutation, of course, that have been studied in all these patients together with other known prognostic markers like immunoglobulin gene status, but also more clinical markers like disease status, but in particular treatment, because the endpoint of the study was time to next treatment. In the next slide, we can see the genes. These are the 10 genes that are frequently, let's say, mutated in CLL, but as I said, between 1 and 5%, with the notable exception of Notch1, where probably around 10% of patients are indeed mutated. As you can see, I will be very quick on this. Most of the mutations are mutually exclusive, but still we have patients who are, so the vast majority of patients who carry mutation carry one mutation, but then we have also, as you can see on the right side, patients who were carrying 2 genes mutation, 3 gene mutation. So this is also what we are planning to assess, how the addition of more mutation associated with the clinical prognosis. Just show you the next slide, which is a summary of the preliminary data, where indeed all mutations except the one on mid-88 are associated with the poor time to next treatment. And now we are, again, as I said, analyzing to see how more mutation together can even have a different impact. So in the next is just a summary of what I just said. So the most mutation except mid-88 are associated with inferior time to first treatment. And all of these 4 genes, SF3B1, P53, EGR2, and BX3, were independent factors in multivariate analysis for the time to first treatment. So now if you go to the next slide, I leave the stage to Lydia, who will be presenting the second project, which is, let's say, unrelated to the first one. So we started a new collection of patient and data. And as you will see, we are now over 10,000 patients involved, aiming for 15,000. Thank you very much. And Lydia, please go ahead.
Good afternoon. Thank you for having me today. Next slide, please. As Paolo mentioned, we are collecting data on a patient with CLL, trying to shed light on the occurrence of other malignancies in this group of patients. This is a well-known gap of knowledge that requires the collection of a large number of cases to be better understand. So we conducted this multicentric retrospective analysis focusing on real-world evidence data. And next slide, please. We try to describe the occurrence of other malignancies in patients with CLLs in terms not only of incidence and prevalence, but also in terms of correlation with potential risk factors. Meaning that we were collecting patient-related, CLL-related and treatment-related characteristic with the aim of a comprehensive characterization of a cohort, of a large cohort of patients. Next slide, please. So our inclusion criteria were based on the collection of consecutive patients followed at each participating site. And we defined the enrollment period for patients diagnosed with CLL between 2000 and 2016 in order to allow sufficient follow-up for developing other malignancies. We collected, as mentioned, disease-related, patient-related, and treatment-related information, as well as, of course, the information on type and diagnosis of other malignancies. Next slide, please. We have the goal to include more than 100 sites in the project. So far, we received data from 65 institutions all over the world. For other of them, we are waiting for the comprehensive data set, and some of them were contacted but did not confirm yet their participation. They are, as you can see, widely distributed across the world. Actually, most of them are based in Europe, but we have also other countries outside Europe involved. Today, I'm presenting just quickly, next slide, please, the result of our very preliminary analysis, where we analyzed, as Paolo mentioned, more than 10,800 cases. Just as general description, the median age was slightly younger than expected in this cohort of patients, being 65 years. And the median follow-up is more than 7 years. Next slide, please. We identified the presence of other malignancies in about 20% of cases included in the cohort, based on the inclusion criteria we previously mentioned. Next slide, please. Here you can see the graph that is showing the occurrence of solid tumors in patients with CLL, and as expected, the most frequent one are malignant neoplasm of skin, followed by prostate, colon, and breast cancer. Next slide, please. And the scenario is more or less the same when we focus our attention on solid tumors diagnosed after the diagnosis of CLL. Next slide, please. We try to analyze the occurrence of other hematological neoplasm in patients with CLL, being, of course, rarer than the occurrence of solid tumors. Here you can see that in the whole cohort, the most frequent hematological neoplasm was actually represented by the category of plasma cell disorders, and we will look in more details on these in the next analysis. Next slide, please. But when we focused on the hematological neoplasm diagnosed after CLL, actually MDS became the more frequent one. Next slide, please. Here we are including in our analysis more or less half treated and half untreated patients in the cohort. And when in the next slide, we try to break down the composition in terms of treatment. The vast majority of patients, more than 80%, have received at least one line of chemoimmunotherapy, but we have also more than 1,000 cases who have been treated with novel treatments. So this would be very interesting to analyze and better understand. Next slide, please. At first glance, actually, we were not able to identify any difference in terms of occurrence of other malignancies in untreated versus untreated patients. Next, please. More than 30% of other malignancies occurred before CLL diagnosis, and more than 65% after CLL diagnosis. And when we focused actually on the analysis of neoplasm diagnosed after CLL, what was evident and in line with previous report from the literature is that the occurrence of hematological malignancies was higher in the group of treated patients. And this was mainly related, next please, to a higher number of patients developing MDS and AML in our cohort. Next, please. So we concluded that actually the strong association between the occurrence of hematological malignancies and in particular MDS and AML and CLL treatment was mainly drawn by the exposure of our patient to chemoimmunotherapy. As I mentioned, more than 80% of cases have received at least one line of previous chemoimmunotherapy treatment. The occurrence of other malignancies after CLL diagnosis in general was about 13%, so I dare say in line with the literature. And we are now focusing our analysis on solid tumor frequencies that did not appear to be increasing in treated patients compared to the treatment naive ones, but is definitely required further analysis. And the plan is to complete the analysis and submit to the next EHA meeting an abstract, as well as for the project on recurrent mutations in CLL. Then we aim to finalize, to complete the data collection and data curation, and to complete the statistical analysis by mid of June, to draft a manuscript and submit it for publication. And in the end, I would like to acknowledge the contribution, the valuable contribution of many sites who were key in conducting the study and collecting the data from this large cohort of patients. Thank you.
So thank you, Lydia. Thank you, Paola. Any plan to submit, to upload this data to the Harmony platform? It will be really interesting to have also the roadmap to have the data inside the platform, because later on it will take time. So it is always the same problem, and you know very well all the troubles before.
Yes, no, indeed. I would say first we complete the submission of all the cases of the first project. As you mentioned, there has been a number of technical and administrative issues, so we want to complete that, and we are moving on with that. And then, of course, we will now, with the experience from the first project, it will be much easier probably to transfer the data from the second project. As you saw, there are many more cases, many more institutions, so maybe some of them have really
and if I may, we already collected the information on the possibility of sharing this data within Harmony. So we have at least this piece of information that should speed up the process of including the data in the database.
And I just want to add one more thing that I forgot, is that Eric is a partner in Harmony, but also the University in Brno with Sharka Pospisilova, and Barcelona with Francesc Bosch, though they are also member of the ERIC, but they are also partner as institution in the project.
Quite sure this will facilitate the data transfer. Thank you so much. And before we will continue, I will also to thank, there is a lot of people attending this meeting. We are now about 120. We have been over 130, and I want to thank all of the patient advocacy groups members who are present on the room, and also the people who is maybe much more out of Europe, Bill Booth from the ASH Data Hub, also Marcelo from the LATAM group of MDS, and of course to Osama, who already left, but also to Com Carol from the IMI office. So I think it is very important to have these all these kind of all the stakeholders present on the room, and really I thank to all of you for the participation. And also I have seen that the chat is sometimes quite active. The chat is still open, and if we will have time at the end of these presentations, we will do a short round of questions. If not, please go to the chat. Okay, we will move to the MDS. We will perform the update of the MDS by two of our key opinion leaders from the field, Valeria Santini from Finmonlus Fondazione Italiana Sindromi, and also by Pierre Fenot from the Groupe Francophone de Myelodysplasie. Valeria or Pierre, doesn't matter. So I think both of you will do some presentation. I see Pierre, maybe also Valeria is also there. Please go ahead. Thank you so much for
good afternoon. So we indeed have two projects. So we're both involved in both, but I will present the first and Valeria the second. So the first project is to assess the effect of hypomethylating agents, mainly azacitidine in high-risk MDS. As you know, they are still the main treatment in this disease category. And so the idea was to collect as much data as possible, in particular molecular biology, I mean mutations by NGS from large European groups. So the idea is that data is starting to be collected, but is not collected as yet. So there is here a delay, and I think I will personally contact the centers to be sure that things go forward. Next, please. So the study population is high-risk MDS and CMML. Most of them received azacitidine. Decitabine is not really approved in Europe, except where some patients with CMML have been treated. It could be alone or with other drugs, not so many followed or not by transplant. And we decided to include intensive chemotherapy. I don't know as yet if the data transferred, there are many patients treated with chemotherapy. Next. So the idea is really all the classical parameters, because prognostic factors of treatment with hypomodulating agents are not very well known. And in addition, we need to define surrogate endpoints, surrogate to survival, which is a relatively late endpoint, of course. And also patients may have second-line treatment, which may have an effect on survival. And therefore, we need earlier endpoints. So in addition to karyotype, mutation, flow, cytometry, there could be other tests like RNA-seq, etc., and immunological studies. Next slide. And so it's really the endpoints we want to assess because the various types of, and to see in particular if event-free survival, progression-free survival could be surrogate endpoints for survival, and clonal evolution when available, and also what is important is the management of infectious complications in those patients. Next. So next slide. So, well, that's the scientific questions, reaching the prognostic value of the various types of response of specific mutations, treatment duration, prophylactic antibiotics, and some subgroups like very old patients, because we're seeing now patients up to the age of 90, CMML, and a few patients with prolonged response, candidates for transplant. Next. And this is the state. I mean, so there's still many groups who have not sent their data. So it's not, I mean, so far we cannot perform the analysis. And so what I'll do is I'll contact in particular Ana Hernandez and to see exactly whom to contact and to go forward, because we don't go fast enough actually if we want to evaluate the data. We have a lot of patients, a huge number of patients, so it's going to be important. A large number of them has had mutational analysis, and a growing number of them, because we know that now it's more and more performed, and so we need to go forward, well, probably faster, but we are the ones to blame probably. We don't recontact the colleagues enough to get all the data as soon as possible. Okay. So this is the second project. So go ahead, Valeria.
Okay. Hello. Thanks. And very interesting, very challenging projects. Our project is the second one we want to propose to Harmony. It stems from an idea of Elena Crisa, who is a member of PHYSIUM, and she proposed this study that I think will be very interesting. So we would like to start with a retrospective study and go on with a prospective study in a setting that is actually collecting a very small number of patients. So we want to understand whether the stopping treatment with lenalidomide in patients in response with MDS del5Q can maintain response, and how many of these patients maintain. So the aim of the study of this first part, which is retrospective, is to investigate the outcome of patients with del5Q who stopped lenalidomide in response. So this is quite difficult because not many patients do stop treatment when they are responding. And the idea is to evaluate whether hematological response is maintained, as well as the cytogenetic, and whether we have a faster disease progression. And then, whoops, sorry, I didn't say, okay. And then we want to investigate the biological markers of relapse, if any. Now, as Pierre just mentioned, we want to evaluate event-free survival, which is a good surrogate of overall survival in a setting in which overall survival is hopefully a little bit longer than usual. Next slide. And what happened? We circulated in the centers that were interested as a taxonomy just to select the variable to study. And the collection of cases has been sort of finished and finalized this month. And we are prepared to transfer the data into the Harmony Big Data platform. We have to finalize the approval of the entire project. Next slide. So very few patients, but 63 patients in this setting are a lot, because it's really difficult to have responsive and responding patients who stop treatment. So that's a typical idea that needs to have a big number of centers. And as you see, for this number of patients, we collected data from a lot of Harmony groups. So that's next slide. This is where we stay now. So we have the HMA project that you just heard from Pierre. And then this LAN treatment discontinuation that is now retrospective, but hopefully in the future prospective. And we would like to finalize the data within the July, within summer 21. Thanks a lot. I think.
Okay, thank you, Valeria. Thank you, Pierre. I think it is quite. MDS is always not an easy disease to collect the data and good quality data that we are required. Regarding Pierre's question, I can share with you that the Spanish group is going to transfer the data in the next days. So the data has been already prepared according to harmonized structure. And also we have very good news coming from the Polish registry with a lot of data that they are also going to share with us. And I'm quite sure that this will increase the number of cases that potentially could be exploited in both projects. So they are really good news. So now I have I guess we have to use this to take the momentum to really finalize these couple of projects. One is a very big one. The other is a small but very structured project. Thank you so much. Okay, let's move to the next presentation. Is regarding acute promyelocytic leukemia, in which has been several rounds of disease in the last weeks or in the last months. And this project is mainly conducted by Tor Vergata University, actually by Maria Teresa Bosso. Maria Teresa, please.
Hello, good afternoon.
Thank you.
Nice to see and hear you all. I would actually let Leonora De Bellis, who is a collaborator of mine, who has been working with me on this project, to present the update of the APL project. Please, Eleonora.
Thank you. Good afternoon. I'm glad to participate to this Harmony February meeting, so thanks for invitation. I'll present and share with you an update about our project on prognostic factors and outcome of acute promyelocytic leukemia. As everybody knows, APL is a rare disease that accounts for about 5–7% of all acute myeloid leukemias. So this Harmony project offers the opportunity to merge data from APL patient population from different European groups, both treated in clinical trials and in real life, with the goal of improving current knowledge about some open issues like management and outcome of these APL patients. In particular, the main investigational fields of our projects are 6. The first one about patient characteristics and their impact on outcome. For example, the presence of a de novo APL versus a therapy-related APL, the type of breakpoint, the sans risk group, the co-occurrence of FLT3 ITD mutations, and the type of treatment. Differentiation syndrome, the benefits of steroid in the steroid prophylaxis for this potentially fatal complication of APL is today controversial. So areas of investigation should include the type of steroid, the duration of prophylaxis, and also if there is a subset of patients that could benefit the most of this prophylaxis. Third, the maintenance therapy. So the survival benefit of the use of maintenance therapy after ATRA plus chemotherapy treatment with induction and consolidation has been explored in randomized trials, and by now we have controversial results. So this should also be a field of interest. In addition, we have also a possible role to investigate of maintenance chemotherapy in the pathogenesis of possible secondary therapy-related myeloid neoplasms. Fourth, the CNS disease and CNS prophylaxis. CNS relapse in APL is an infrequent presentation, but it is associated with a poor prognosis. We know that usually it occurs when we have a high-risk disease and when we have a prior CNS hemorrhage. But to date, we have no clear evidence of a benefit in doing CNS prophylaxis, and also the management of a CNS relapse is not clear. We have also interest in studying elderly patients, because also, often elderly patients are not enrolled in clinical trials, so we probably know less about them. And finally, we have another big chapter that is the evaluation of the quality of life of these patients in terms of long-term assessment. Next slide, please. This project started in October 2020, and since that moment we had the confirmed adhesion by 8 European collaborative groups. We had 2 teleconferences, and the next one is scheduled for the 24th of February. We have 4 out of 8 groups that prepared and collected the data dictionary, and 2 out of 8 groups that also signed, have already signed the data sharing agreements and started a data transfer. Next, please. During the past meetings, we also defined and divided some sub-projects that we identified, like the characteristic of APL at diagnosis and their impact on outcome, the long-term complications in APL, with a particular interest in the development of secondary neoplasms, including solid tumors or therapy-related myeloid neoplasms. The resistance to ATO, so the molecular characterizations of ATO-resistant APL, and finally, the quality of life in APL according to treatment strategy. Next, please. This table shows the expected number of cases. We included both patients from clinical trials by different European groups and also treated in real life. In light blue, you can see the GMEMA Italian group and the Study Alliance Leukemia German group that have already, as I said before, have already started the data transfer of about 400 of patients. Next, please. This is the present status. So we have 4 out of 8 groups that established, defined the data dictionary, 2 that shared, signed or have already signed the DSA and started the data transfer. About the other 6, 3 of these groups have already a DSA for AML, so they only need an addendum, and the other 3 are in phase of reviewing DSA. Next, please. And this is the roadmap of 2021 with our goals placed at different time points. So we expect to conclude the DSA revision addendum phase within the first quartile and the data transfer within the first half of the current year. On this way, we will be able to conclude the first analysis of data reaching about 1,000 of patients, APL patients, in order to send an abstract for ASH 2021. Moreover, we expect to conclude the collection, the data collection within the end of this year, and then start further sub-projects in 2022. Thank you for attention.
So thank you, Eleonora, and thank you, Maria Teresa. I think it is really a really very important project in APL, and quite sure that all of us will really appreciate. I'm also happy to see that most, if not all, of the projects already contain data coming from around 10 different working groups. So it means that overall, we are covering, let's say, hundreds and hundreds of hospitals, of different hospitals that they are willing to share the data with us and to see this common effort. This is really amazing. Okay, so thank you so much. And now we will move to the last topic in this part of the Harmony meeting, and this is the update in AML that it will be performed by Professor Lars Bullinger from Charité Hospital in Berlin. Lars?
I'm there, yes. Hello.
Okay, perfect. Thank you so much for accepting the invitation to present the data in AML, and we will see how the AML project is progressing. Thank you so much.
Yeah, thanks for the kind introduction. Can you hear me? Yeah, okay, good. Yeah, so sorry for being late. I couldn't join the meeting from the very beginning, so I missed some of the talks, but we had a very important meeting with our local authorities regarding a new building where we try to produce advanced therapy medicinal products, so I could not postpone that meeting. But I'm now happy to be with you and to give you an overview of what we have achieved in the last year. So we were lucky to put together over 5,000 data sets that are really now already in the database. There is more cases to come. And based on these cases, we have started to implement the workflows in the Harmony database. We have also presented first results of our pilot study at last year's ASH meeting. So next slide. You can see that with the data in the database, we can model clonal evolution. So this was a model established by Eric Streng in our group at the Charité. We performed a Bradley-Terry analysis to demonstrate, based on the variant allele frequency, in which order the mutations most likely have occurred. So while this, of course, is recapitulating what we know about the disease, this was one of the analyses which we wanted to do to also make sure that the data did not get corrupted during the harmonization process, and that we see what is expected, for example, that the mutations linked to DNA methylation are early events, and that analysis of that large data set also showed that histone modifying enzyme mutations, for example, occur in general later than the DNA methylation aberrations. Then we also, of course, use the platform to evaluate gene-gene interactions. That analysis also occurred known co-occurrence patterns. For example, that NPM1 mutations are mutually exclusive to biallelic CBP alpha mutations. On the other hand, we could identify new co-occurrences that have not been shown in that way before. The large data set, for example, could show that ECH2 mutations come very often together with RUNX1 mutations, or we also, for example, could show that the RUNX1 mutants very frequently harbor mutations, which we also see in MDS, such as SRSF2, SF3B1, or STAT2. Then, together with the colleagues in the AML working group, we also thought what could we do in addition with these large data sets, and one of the ideas was to further study the impact on age. Could we define a cut point where the biology of the disease starts to differ? And there we also had started to do the first analyses. Then, in collaboration with the colleagues from Bologna, that's part of the Work Package 5 group also, we, in the next slide, could see that the data is also able to recapitulate known molecular classified groups. So using the Dirichlet process that had previously been published by colleagues in the Sanger Institute, Moritz Gastung and Peter Campbell's group, we ran this multivariable analysis to identify molecular defined leukemia subgroups of prognostic relevance. And here we, for example, could also recapitulate the previously discovered subgroups AML with poor prognostic impact, that is due to the mutational pattern by P53 mutation and the chromosomal rearrangements linked to that mutation. And then we also, for example, could recapitulate the previously defined AML subgroup with IDHR 172 mutations. And then on the next slide, you'll see that we also now started to use that database to implement models that will allow us to predict outcome for patients individually, similar to what we had previously also published in Nature Genetics together with Peter Campbell's group. But this process now was further refined by the colleagues from Salamanca, Angela and Javier from Jesus group. And this now allows us to individually predict response, for example, to allogeneic or conventional chemotherapy for patients based on the underlying genomic aberrations. And the nice thing here for that model is that it will be constantly updated with new data coming into the database, and it also will give you an overview of the impact the distinct variables will have on a patient's individual outcome. And in the future, we also might be able to address these individual factors in more detail, perhaps by getting rid of some of the risk factors or by directly targeting some of them with new therapeutic approaches. And we hope that tools like this will be very valuable in the future for better management of our patients. The next slide. So what has then been happening since December? So in the last 2 months, we have started to have regular meetings of the Work Package 2, that's the AML team, together with the Work Package 5, sorry, I'm missing a P here, team who is implementing the data analysis algorithms. we started or continue to work on these topics. We started to look at new topics, such as, for example, the impact of gender. We are, of course, continuing to include new data sets, and there's also new bioinformatics groups that will join the Work Package 5 team with a lot of expertise in analyzing AML data sets. And within the next few slides, I show you some updates. So we continued the calculations and the impact on gene. So if you only look at co-occurrence, gene-gene interactions, the age difference seems to be shifted rather towards a 60-year limit, where then the biology is really changing. And then what you also can look at individual peaks that seem to cluster with distinct mutations. So we will use these analyses to better understand the biology, and also with regard to the background based on which the disease is evolving. On the next slide, you can see that we now also started to work on gender aspects. With this large data set, we saw that there is a slight trend towards better outcome for female patients. We started to have a more detailed look what could be the cause for that. That analysis that was again done by the colleagues in Salamanca nicely demonstrate that this has also been shown in literature, that there is a difference with regard to the presence of NPM1 mutations that are more frequently seen in female patients, for example, than in male patients. On the other hand, high-risk mutations such as SRSF2 are a little more frequent in men than in females, and that can, for example, in part already explain the differences which we are seeing here. But in my opinion, that's a very interesting new finding or observation based on such a large data set, and we are digging deeper into that analysis. On the next slide, you then can see that we are also further refining these molecular classification models. Please apologize the typo here for Ellie's name. Papa Emmanuel should be having only one P and two M. But we are now using the algorithm. We have refined that algorithm by improving the filtering criteria. We have improved the imputation strategies. In that way, we can further refine the molecular classification, and we also can identify new molecular relevant leukemia subgroups. And on the next slide, you can also see that we continue working on this individualized outcome prediction, where we now have some additional players in the team. Axel Benner's group, who has done for many years the outcome analyses for the AMLSG study group. He and his team will support Angela and Javier in optimizing these random forest classifiers to really then allow us to implement the tool, which then, for example, could also be accessible through the Harmony webpage, where then Harmony members can also look up the individual risk profile for newly incoming patients by comparing the mutational profile to the ones present in the database. And with this, I'm almost at the end. I think you already heard about Harmony Plus, where we will now implement new hematologic diseases. We will also do the same things for CML, myeloproliferative diseases, and Hodgkin disease, like we have done for the other hematologic malignancies. And then we really have a complete picture within Harmony for hematologic diseases, which allows us then to have a platform that also can support the clinical trial design, that will provide valuable information for all healthcare stakeholders. And then it also has been mentioned that we then can, of course, also use Harmony to, for example, interact with other respective databases. And I think you just heard a very nice example of the interaction which we have started together with the American Society of Hematology. And I think all this then will lead definitely to the sustainability of the Harmony project. So I also was asked to give a very short wrap up of everything. So this will be shown on the last slide. So where are we standing today? Can you please move forward one slide? Yep. So today already 30,000 data sets are present in the Harmony database. They all have been entered. There is 20 more who are currently waiting to get in there. So data dictionaries have to be generated, or they are already generated, and the data sets are in the queue for the trusted third party before they are then put into the harmonization process, which is run by GMV, but they will be in the database within the next weeks. And then in addition, there is already over 10,000 data sets where the data sharing agreements is still in negotiation. And we already also have discovered additional data sets where this process was just started, especially if you think of the APL project, which you just heard the talk before mine. So I think we are on a very, very good way to really include the 100,000 data sets, or at least 70,000. So this was the aim which we had written, 10,000 per disease. But I'm pretty confident that we will reach the 100,000 data set margin by the end of Harmony. And then we, of course, can continue that effort within Harmony Plus and also put together all the additional data sets for the 3 new incoming diseases. And I think the talks which we have heard today really provided a very nice overview of what now started to go on in Harmony, and that many cool projects are coming out of Harmony, and that we will see many more interesting results in the next weeks, months, and this year. And I hope that we all can also meet in person again later this year, and then share the results together in presence. Thank you very much.